వస్తుంది.
Okay.
Good morning, all. Today, Dr. Srikanth is going to talk on a new topic in critical care. Is a central role of gut microbiota in critical care. I request Dr. Srikanth to start the presentation.
Good morning, sir. Sir, thank you. This basically.
No, David, only ante introduction is alaga Srikanth ki.
Sir, I see.
Introduction already given number of times.
I see the
అలా కాదు కొత్తగా ఎవరైనా సరే జాయిన్ అవుతే మరి క్లాస్ లో వాళ్ళకి తెలియాలి కదా, మన వాళ్ళే కాదు కదా, మీరు నేనే తెలీదు.
Okay. Dr. Srikanth,
all his credentials, at least clinical experience and expertise and position.
Sir, IC related ga anta experience. But okay.
Okay, Dr. Srikanth is the only and senior most and whole and soul intensivist and anesthesiologist in ABC Hospital, Visakhapatnam. He is a lot of interest in critical care while he is doing practice in anesthesia, and he is a pain specialist also, doing a lot of presentations in pain management in national and state conferences. I request now Dr. Srikanth to start the presentation. Thank you, Srikanth.
Thank you so much, sir. So coming to this topic today, I found it interesting. It's based on a open access review article published in BMC very recently. Like it was published in around August, like that, in 2022. So we maybe my idea of gut microbiota till I read the relevant articles over here is like we in ICU, due to medicines or any interventions what we do and all, the gut microflora, and due to diseases, gut microflora will be definitely disturbed, and the use of probiotics in diarrhea cases we all know, for children and adults also, and in some infections, and FMT, fecal matter transplantation. I have heard a bit, not into so much details. So this is basically an extensive topic. I tried hard to make it into the presentation time allotted. So it's a bit boring, but I will try to make it as interesting as possible. So in this class, we will actually go through the physiology, like how gut interacts with all the major organs in the body first, and then how we can harness the gut microbiota, especially in critical ill. So the thing we have to keep in mind is at this point, like this article is just published a couple of months back. So at this point, we stand with a very weak evidence regarding all the interventions we do with the gut, and still more studies are needed, and larger evidence-based trials are yet to come. But this is still an experimental phase, and most of the studies are in phase 1 trials and phase 2A, 2B trials. So this is the status of the interventions or clinical interventions what we do regarding the gut microbiota. So with this, we'll start this. Coming to introduction, the number of microorganisms inhabiting humans is approximately 3.8 to 10 to the power of 13. Collectively, they constitute the human microbiota, representing an organ itself. So the gut microbiota of healthy subject harbors all three life domains: bacteria, archaea, and eukarya. But the bacterial domain is the most represented. There are 6 known bacterial phyla. Firmicutes and Bacteroides are the most abundant, followed by bacteria and proteobacteria. Basically, the composition varies among individuals, changing throughout life due to intrinsic factors like age and genetics, and also external modifiable factors like diet, environment, and drug usage. So coming to the functions of gut microbiota, enterocyte renewal modulation, which is making fresh regeneration of epithelium and also enterocytes, which help in the routine gut functioning, metabolic and antimicrobic actions, and systemic activities such as improvement of glucose sensitivity, reduction of systemic inflammation, and etc. So what happens basically in critical illness? So in the ICU, patients are subjected to antibiotics, gastrointestinal transit changes, nutritional changes, and in sepsis in infective cases, collectively leading to a GM imbalance. GM represents gut microbiota in further slides, namely dysbiosis. So the term coined to this disturbance, what we are getting in the gut flora is termed dysbiosis, whose most common symptom is diarrhea. So 90% of the intestinal microflora is lost within 6 hours of ICU admission. This is proved in majority of studies. So ICU patients will have a relatively lower bacterial diversity and variability. And because of this, opportunistic pathogens and multi-drug resistant organisms are enriched over the symbiotics. So most opportunistic pathogens are gram-negative aerobic proteobacteria such as Enterobacteriaceae and gram-positive bacteria such as Staphylococcus and Enterococcus species. So this imbalance can lead to Candida albicans overgrowth in critically ill patients, while beneficial species such as Ruminococcus, Pseudobutyria vibrio, and Faecalibacterium prosnici become less represented. So this imbalance basically leads to overgrowth of opportunistic infections and organisms and multi-drug resistant organisms, and also fungal growth, and beneficial species are reduced. So for these reasons, the gut microbiota in critically ill patients is defined as pathobiota. So this is how the microbiota of the normal, which is commensal bacteria, symbiotic bacteria, are transformed into pathobiota due to antibiotics, ICU-specific treatments, and critical illness. So where opportunistic pathogens and multi-drug resistant organisms will take the main seat. So this is how it is represented, how the gut microbiota or the gut interacts with the remaining body, to heart, to the major organs are discussed mainly. So we will deal with each organ separately now. So coming to gut-brain axis, the gut-brain axis was first described in early 2000s when antibiotic-treated germ-free or specific pathogen-free mice developed neurological problems. So this axis is actually initially described, most of the studies they have done in mice as experimental animal. So where previously germ-free or specific pathogen-free mice, when they were treated with antibiotics, they developed neurological problems. And the gut-brain axis links brain's emotional and cognitive centers with the gut. So the lactobacillus, bifidobacteria, enterococcus, and streptococcus produce acetylcholine, GABA, and serotonin. These play a big role in the brain activities, as we all know. So 95% of the serotonin is produced from tryptophan in the gut by the microbes. The gut microbes also produce short-chain fatty acids such as butyrate, acetate, and propionate by fiber fermentation. The SCFAs, short-chain fatty acids, contribute to maintaining the gut and also the blood-brain barrier physiology. So when due to the illness or some ICU intervention, the dysbiosis happens. So it will lead to the formation or increase of creation of an inflammasome due to the neuroinflammation. So what is this inflammasome? This inflammasome is a biological complex of the innate immune system, multi-protein oligomers that activates the immunoinflammatory responses. So once the dysbiosis comes, this formation of inflammasome occurs, and activated by pathogens or stress signals like the interventions in critical care, the inflammasome assembles, producing the pro-inflammatory cytokines IL-1 and IL-18 implicated, and these pro-inflammatory cytokines are implicated in the neuromodulation, neuroinflammation, neurodegeneration, and pyroptosis. So this is actually the status we are discussing about in the initial slides. No human studies are available. A recent preclinical study has shown how the gut microbiota plays a part in sepsis-associated encephalopathy by improving the neurological outcomes when indole-3 propionic acid, a microbial neuroprotective metabolite, is produced, leading to inhibition of the inflammasome activation and the IL-1B secretion in the microglia. So these studies, all these studies, they have tried to like inject or feed the mice with beneficial acids, amino acids, which are produced by the gut microbiota or the live bacilli, and thereby how much the inflammation is decreased or the pathology is reversed. They have studied in all these preclinical studies. So similar preclinical results have been found in model of sepsis-induced cognitive decline, emphasizing the link between gut microbiota dysbiosis and the brain. Coming to gut-heart axis, so dysbiosis and consequently downregulated production of short-chain fatty acids concomitant to a higher level of uremic toxins. So these are decreased and uremic toxins are increased, which will negatively affect the gut-heart axis. So in this context, like lower SCFs and higher uremic toxin production have been observed. So this is accompanied by an increased absorption of lipopolysaccharide and endotoxin due to epithelial dysfunction, which ultimately triggers the systemic inflammatory response. So the sequence of events actually facilitates the development of atherosclerosis and sequentially heart failure. Conversely, like how the intestinal dysbiosis causes heart failure, conversely, heart failure also causes dysbiosis, which promotes intestinal barrier damage, impairs the nutrient absorption, and primes a vicious cycle that goes on. This dysbiosis causes, aggravates the heart failure, and heart failure in turn aggravates the dysbiosis, leading to harmful microbial product translocation into systemic circulation, further aggravating the heart failure. Endoxyl sulfate and p-cressyl sulfate, uremic toxins derived from tryptophan and tyrosine fermentation, play a key role in this context, in this vicious cycle. So they promote fibrosis and in clethodeficient and wild type mice, negatively affecting the heart and kidney function. So observational data in patients with heart failure show decreased intestinal blood flow and edema in the terminal ileum and colon, which leads to change in the gut microbiota composition. This is how the heart failure causes the dysbiosis, with enrichment of Campylobacter, Shigella, and Salmonella. Several heart failure therapeutic strategies targeting the gut microbiota, such as probiotic supplementation and diets, are being clinically and preclinically tested. So coming to few studies in the pilot human trial, Saccharomyces boulardii supplementation in heart failure patients actually improved the left ventricular ejection fraction and also decreased left atrium diameter. This is published in 2015. And there is a converse study to this, the gut heart trial, studying gut microbiota manipulation to treat heart failure did not confirm the previous findings, possibly due to lack of substantial dysbiosis in the enrolled patients. This is published in Lancet. So coming to choline and heart failure, choline is another soluble nutrient linked to heart failure. Heart failure is worse in wild type mice fed choline supplemented diets. Certain gut bacteria such as Enterobacteriaceae can actually metabolize choline to trimethylamine, but when these are decreased due to dysbiosis, the metabolization does not happen and the heart failure worsens. So trimethylamine should ideally remain in the intestine, then there will be no problem. But however, like we discussed in the previous slides, in the heart failure, there will be intestinal edema and then leaky gut, which will cause the TMA or trimethylamine translocation to the liver, where it is converted into trimethylamine N oxide. So which will actually cause both liver as well as heart damage. So coming to gut-lung axis, neonatal gut dysbiosis with reduced bifidobacteria, Akkermansia, and Faecalibacteria may cause CD4 plus T cell dysfunction associated with childhood atopy and asthma. IBD patients or inflammatory bowel disease patients carry a higher risk of pulmonary diseases. In fact, IBD patients commonly have small and large airway dysfunction, obstructive and interstitial pulmonary diseases. So no bacterial pathogens were identified in these patients' sputum cultures, and corticosteroid therapy was required, which obviously suggests a pulmonary impairment due to inflammation and not due to infection. So short-chain fatty acids may act as anti-inflammatory molecules and barrier keepers in the respiratory tract. Though no short-chain fatty acids were directly found in the lung tissue, but their levels promoted dendritic cell hematopoiesis and activated T helper 2 effector cells in the airways, establishing a de facto gut bone marrow lung axis, protecting mice from allergic lung inflammation. So this is a study which was published in 2016 where wild type mice depleted of gut microbiota with due to antibiotics, subsequently intranasally infected with pneumococcal pneumonia, and then they are subjected to fecal microbiota transplantation. Then after FMT, they showed an enhanced primary alveolar macrophage function thanks to a gut microbiota beneficial reshape, which is FMT, fecal microbiota transplantation. This is another study published in 2019. So where they found a relation with the ARDS2, acute respiratory distress syndrome, could be linked to gut microbiota dysbiosis, as ARDS patients presents enrichment of Enterobacteriaceae in the gut and lung while displaying lower bacterial diversity. So coming to gut-kidney axis, uremic toxins, short-chain fatty acids, and D-serine established the so-called gut-kidney axis. So the abnormal levels of endoxyl sulfate, picresyl sulfate, and trimethylamine contribute to the onset of renal tubular cell dysfunction, pruritus, fatigue, neurological damage, coagulation, and endothelial dysfunction. And all these are especially affected by the chronic kidney disease patients. So renal failure leads to higher urea concentration in both blood and intestine. This will in turn cause an overgrowth of intestinal bacteria owning urease activity, converting urea to ammonia and leading to dysbiosis. So patients with CKD and end-stage renal disease subjected to hemodialysis display more enrichment of Faecalibacterium and Bifidobacteriaceae and Probiotics. Conversely, in ESRD patients subjected to peritoneal dialysis, they have this high species of Escherichia genus and Enterobacteriaceae, Enterococcaceae families. So uremic toxins also accumulate in AK, but the underlying cause of this association remains uncovered. So these are a few studies where Bifidobacterium bifidum BGN for supplementation mice previously subjected to bilateral renal ischemia reperfusion injury attenuates the AK severity by modulating the inflammatory immune response. Also, it emphasizes the oral administration of amino acids amino acid D-serine in mice elevated the renal damage, pointing to D-serine's renoprotective properties. So potentially this D-serine levels could be used as a biomarker for AKA patients. This study of D-serine was published in 2018. So coming to gut-liver axis, the liver interacts with the intestine by producing bile acids, while the intestine interacts with the liver by metabolizing bile acids, amino acids, and exogenous components like alcohol and choline. So Enterococcus picaris contributes to alcoholic liver disease, Klebsiella pneumonia to non-alcoholic steatohepatitis, Enterococcus gallinarum to autoimmune hepatitis pathogens. So as bile acids and gut microbiota communicate with each other, disrupting this delicate balance can lead to intestinal barrier impairment, inflammation, and even contribute to cancer onset and development. So damaged intestinal barrier allows bacteria to enter the portal vein and reach the liver, exacerbating the liver and intestinal diseases. So Akromenacia mucinophilia, which is a protective anaerobe actually colonizing the intestinal mucus, is decreased in liver damage. So basically the short chain fatty acids and the long chain fatty acids are the gut liver messengers. So studies in rodents have shown that reducing SCFAs increases intestinal permeability, while reducing the long chain fatty acid decreases the luminal lactobacilli. So supplementation with lactobacillus probiotics in animal models improves the intestinal barrier integrity and inhibits the colonization of the infectious bacteria. So no study has explored like preventing or treating liver dysfunction in the ICU using GM modulators. So previous research on the adjuvant benefits of probiotics, prebiotics, and symbiotics, the fecal microbiota transplantation, bacteriophages in non-alcoholic fatty liver disease and alcoholic liver disease could lay the groundwork for their future employment in the other clinical contexts. So coming to the practical application, how can we actually harness the microbiota in critical ill? So despite the emerging data, there is lack of human studies, especially on critical ill patients, and the available data should be expanded and validated in clinical trials. Moreover, a further effort to address the biomarker discovery should be made in this field, as indicated by potential shown by trimethylamine oxide and D-serine. A potential strategy they have devised based on the available clinical data is where nutrition is the first and easiest step in managing dysbiosis in the ICU patients, followed by probiotics, prebiotics, symbiotics, beta-lactamase, adsorbent charcoal administration, and finally fecal matter transplantation. So we'll come to each and every intervention separately. So these treatments require validation with a higher level of evidence than which is present at this point before they can be routinely applied in ICU. So they must be used with extreme caution, aiming for a tailored approach to the patient with ideal efficacy and safety. So this is the overview of the current clinical status. As we can see, when it comes to grade of evidence, all the nutritional approach, adsorbent charcoal or probiotics, for most of them, it's very weak to weak evidence as of now, with only preclinical studies, some case reports, and few of the phase 1 and phase 2 trials are going on for majority of them. So coming to nutrition, this is altogether a different subject to discuss in a separate class, but just a brief overview regarding gut microbiota. So most of the points we know: quantity, quality, fiber content, and feeding patterns affect the gut microbiota abundance and diversity. Nevertheless, it has been observed that enteral nutrition obviously benefits the gut microbiota more than the parenteral nutrition. So parenteral nutrition raises the bacteroides level and intestinal permeability, which is again dangerous in wild type mice. So enteral nutrition should be preferred for the intestinal barrier integrity to prevent villi atrophy and promote eubiosis, ultimately leading to lower mortality and morbidity and fewer infectious complications. So gut microbiota is affected by the macronutrient to fiber ratio in enteral nutrition formulas. A high protein and animal fat will enrich the GM bacteroides, while carbohydrate-rich diets increase the Prevotella strains. So low fiber intake impacts the gut epithelium integrity, mucous layer thickness, and enrichment of pathogenic strains. So high fiber should be taken in critical ill patients. So coming to probiotics, probiotics are live microorganisms that provide a health benefit to the host when supplemented in sufficient quantities. Probiotics promote eubiosis, reduce gut cell apoptosis, and support the immune system. So, sorry. Coming to the study, this was done in around 2,900 critically ill patients on probiotic use in ICU. Reported that strains such as Saccharomyces, Lactobacillus, and Bifidobacterium are associated with a reduction in infections, particularly in patients with ventilator-associated pneumonia and treated with antibiotics, but not to increase the survival. So they have observed a reduction in infection incidence, especially in ventilator-associated pneumonia, but not to increase the survival. They did not find any significant benefit. So conversely, another large study which included 8,339 patients from 31 RCTs advocates that the safety of the probiotics should be further studied. This is a very recent article published in July 2022. Further studies, especially in critical ill patients, as in some cases, high dosages have been linked to an increase in infectious complications such as sepsis, pneumonia, abscess, and endocarditis due to bacteremia and fungemia. So the other potential indications for probiotics and ICU include sepsis, traumatic brain injury, and most recently SARS-CoV-2 infection. Since 2007, the gut has been conceptualized as a motor that when impaired could drive systemic inflammation and multiple organ failure. So the experimental evidence point to Faecalibacterium prausnichi as a probiotic strain potentially blunting systemic inflammation during sepsis, as it produces an anti-inflammatory peptide that can counteract the chemically induced colitis in mice. So daily oral intake of Lactobacillus and Bifidobacterium has been shown to reduce mortality and improve intestinal epithelial homeostasis in a murine model of septic peritonitis. But probiotics could also be a valid asset in traumatic brain injury, as shown in mice subjected to traumatic spinal cord injury supplemented with VSL3, a mixture of 8 bacterial strains. So this intervention supported mice immune response in the gut and better locomotor recovery, improving post-injury outcomes. So the next generation probiotics are in development now. SER109 is one such, is obtained by transplanting Faecalis microbiota with alcohol-triggered massive sporulation. This new probiotic reduces the risk of recurrent Clostridium difficile infection, RCDI, in patients treated with antibiotics as per guidelines. So this is also a recent article published in 2022 in New England Journal. So prebiotics, coming to prebiotics, prebiotics are the specific nutrients for intestinal bacteria, while symbiotics combine prebiotics and probiotics. So despite the emerging evidence on harnessing the gut microbiota through the use of nutrition and these pre, and symbiotics, the fine mechanisms describing the published observation are still lacking, and this complicates the actual scenario of translating these clinical interventions from bench to the bedside. Coming to beta-lactamase, so this is a commercially the preparation of beta-lactamase ribaxamase, formerly SYN004, and orally administered beta-lactamase with IV penicillins and cephalosporin has shown promising results in preventing dysbiosis in hospitalized patients with lower respiratory tract infections treated with ceftriaxone. A phase 2b study has shown RCDA risk reduction in the interventional group. RCDA refers to recurrent Clostridium difficile infection. So ribaxamase is also effective when administered with beta-lactamase inhibitors like tazobactam and sulbactam. So coming to adsorbent charcoal, DAV132 is the one that is being actively studied, charcoal-based adsorbent. So it was developed actually for the oncological patients for whom therapy is mandatory to prevent the infections because of their immunocompromise. So DAV132 is designed to become active in ileum, cecum, and colon before antibiotics could start impairing the gut microbiota. So coming to study, which is another one published in 2022, a phase 2 trial has confirmed that DAV132 can be safely used in patients as it is well tolerated and promotes the gut microbiota diversity by improving Clostridioides difficile colonization resistance. And therefore, despite the lack of proper studies or large-scale studies in critical illness, DAV132 could potentially be an additional tool together with probiotics administration to reduce the RCDA incidence and progression risks in ICU patients. Coming to fecal microbiota transplantation. So FMT is a medical technique in which stools from a healthy donor are delivered to a dysbiotic patient to restore the eubiosis. An FMT sample contains all microorganisms that naturally harbor in the gut and their associated metabolites. For this reason, this treatment may restore dysbiosis better than the others. However, this procedure does not come without risks like all transplantations. In fact, undesired or undetected pathogens could also be delivered from the donor to the recipient subject, and sometimes even with fatal complications. In a case report, 2 patients developed drug-resistant E. coli bacteremia following FMT, causing 1 death. Therefore, extreme caution should be taken, especially in critically ill patients with a high risk of infection. So in 2017, a panel of experts from the European Consensus Conference drafted FMT recommendations. To date, the main indication for fecal microbiota transplantation is recurrent RCDA infection, where efficacy is superior to antibiotics. So in the other fields, they're actually exploring now, but even in the 2017 guidelines, they have accepted this indication of recurrent Clostridium difficile infection as the only indication for fecal microbiota transplantation. So briefly, before closing the session, we'll briefly go through the guidelines of fecal microbiota transplantation, which were published by the European Society in 2017. So key issues to select potential donors, they should be screened for infectious diseases, GI, metabolic and neurological diseases like all this. I will share the articles as well as PPT in the group later. Sorry. And care should be taken about any intake of drugs that can impair the gut microbiota composition. And then we have to look at the issues to address on the coming to the right side box, issues to address on the same day of donation to check any recently onset of harmful effects. So newly appeared symptoms or newly appeared illness when the patient was initially, donor was initially considered for transplantation, and between that time period, any new onset symptoms and all, we have to take into consideration any use of antibiotics or travel and all, or diarrhea. Then these are the testings that are done to check the donors for any potentially transmittable diseases. So general blood testing in specific situations, and also general stool testing and stool testing in specific situations. And then this final guideline box, what we are seeing. So this I will read in a bit detail. So these are the minimum general steps to follow for the preparation of fresh as well as frozen fecal material. So the fresh fecal material, it should be fresh stool should be used within 6 hours after defecation. To protect the anaerobic bacteria, the storage and preparation should be as brief as possible. So until further processing, the stool sample can be stored at ambient temperature at 20 degrees to 30 degrees. Then anaerobic storage and processing should be applied if possible. So minimum amount of 30 grams of feces should be used, and fecal material should be suspended in saline using a blender or manual effort and sieved in order to avoid the clogging of infusion to the syringes and tubes. So a dedicated space disinfected using measures that are effective against sporulating bacteria should be used. Protective gloves as well as face masks should be used during the preparation. Coming to the frozen fecal material, so at least 30 grams of donor feces and 150 ml of saline solution should be used. Before freezing, glycerol should be added to a final concentration of 10%. The final suspension should be clearly labeled and traceable and stored at -80 degrees. On the day of fecal infusion, fecal suspension should be thawed in warm water bath and infused within 6 hours from thawing. After thawing, saline solution can be added to obtain a desired suspension volume. Repetitive thawing and freezing should be avoided for the frozen fecal material. So these are briefly the guidelines and all. The detailed article about fecal microbiota transplantation, the guidelines I will share in the group. So coming to conclusion, recent evidence has shown that critically ill patients display a changed gut microbiota known as pathobiota. The pathobiota composition is one of the leading causes of clinical complications. Targeting the intestinal bacteria has the potential to preserve or restore bacterial barrier integrity, which would then prime a beneficial cascade on the organ dysfunctions arising in the ICU patients. New studies designed for critically ill patients should reinforce the current evidence, such as preventing VAP probiotics, treating recurrent Clostridium difficile infections, and the multi-drug resistant organism colonization by the fecal microbiota transplantation. So further studies are needed, further high quality evidence are needed, as mentioned, for translocating all these interventions from bedside to bedside, as said by the author. But knowledge of things that are going on, as this is the final critical care session of 2022, I thought a recent article would do some justice, and I was very much fascinated by the learning I got through, even though I could not do proper justice to the class. This is a very extensive topic. So I will share all the relevant articles by the evening, and thank you so much for the patient listening. I know this is a very boring class. Thank you so much.
Not at all bowling, Shrikant. It's really nice and very good topic actually, and very nicely covered within the given time. And you sent the PPT as well as relevant articles today to the group. And with all your permission, Dr. David.
Sir.
can I ask Ravinder Reddy to join just for a question answers because the expert opinion of his this one is actually. మీకు రవీంద్ర రెడ్డి తెలుసు కదా?
Ravindra Reddy, yeah, surgeon.
Surgeon who is a nutrition
specialist. Yeah, he is a very famous.
Yeah, it's not famous, good in a subject also. I thought because somebody can be famous without good in subject like me, that's also different. So it's not like that. So he is good in both. So that's why, can I ask him to join just for a question answer something after our discussion of 10 minutes?
Yes, sir. Ask him to join. Send the link.
Yeah, I'll send. So only thing is I request now a lot of things, questions are there. Now, is it going to change our Dr. Srikanth? Can I ask David?
Sir.
Yeah. Srikanth, if early nutrition, because every one of us are more worried about starting in nutrition late. Even if the patient is in shock, if you have a little feeds, can that prevent this translocation theory or gut problem, other things, anything? Can anyone tell me that? Tropic feeds, you say, are minimal starting, because when the patient is really in shock, yes, they say that it's going to be problematic. But even at that time, we have a minimal this one, so that the gut flora damage will be less. As you said rightly in the beginning, within 6 hours, because when you put the patient in anesthesia, if you give anesthesia drugs, all the ciliary active of the lung is gone. So like that, when you put the patient in ICU, because not healthy patient, but any sick patient, automatically entire microbiota, microbe of intestine, everything changes. That is gone because you said organism itself, entire one separate organ. So those interactions that as HIT theory or gut theory, whatever we talk about, that is going to prevalent and bacteria is going to take over. So with this, do you think that early nutrition is going to really change better? And in that nutrition, you use a good material of whatever you want to give. I just want to ask you.
This anti-nutrition is definitely preferred, sir, and maybe David sir could better like.
Yeah, even though it is different, as he said, even patient in shock on a very high dose of inotropic support, he can wait for 48 hours. You need not start immediately. Can
that
wait
is
for
what
48
my
hours.
Dr. David sir, as per guidelines that has been said, my feeling as per the theory presently Srikanth expressed told is that within 6 hours, gut is going to become empty and it's going to make an open system for all bacteria. So that reason why we should wait for 48 hours, because any 6 hours are minimal, because you start with a little bit of water or a little bit of liquid, only 10 ml, so that like a dryness will go away. And if you remember very well, I don't know, it is not at all relevant to the class. When cardiac surgery is going on, when the heat comes to the heart, the dryness, we used to put a saline also to make it wet. Like that, gut also, it's continuously wet and it becomes dry if you don't give. So do you think that minimal giving a fluid?
Right, correct. But what the guideline says?
I understand, sir.
Sir, guideline says two things, sir. One is blood pressure. Previously, they used to say that high vasopressors don't wait, but now what they say is systolic blood pressure of more than 90. They even in spite of vasopressors, you can start on feeding. I think plus during massive fluid resuscitation, he says wait. But I think my gut feeling, sir, I think as you mentioned, better to start as early as possible, because we try to maintain a blood pressure of 90 in any cost. But only thing is, as we all know that when the aspirate is high or not tolerating, we can stop it. That is my opinion, sir.
No, as you said rightly, Dr. Jekina, BP
Yes,
more than 90 can be given, right? So
yes,
if the patient is been intubated, as soon as you intubate not because of hypotension, not because of maybe hypoxia, or at the time of drugs hypotension, within another few hours, why don't you start register feeding if the aspiration is not there? Why we want to wait?
sir. Yes, sir. We will start as soon as possible. Check, do a chest X-ray and check X-ray. If the right tube is in position, start it.
Because I have seen when some of my colleagues are delaying it for thinking it's 1 to 2 days, because they don't give anything in first hour, because maybe like old system of Lankanam Paramaushidam, I don't know what is the real reason. So I know scientifically I am not able to prove it, but that's what I am really feeling it. Gut microbiome.
No, it has to be done as soon as possible.
Yeah.
Sir.
Yeah, we are starting the 10 ml per hour that
Tropic feeds.
tropic feeds. 10 ml.
That is what
Okay.
I am asking. I am asking only that much
Yeah.
only. I am not asking the feed. I am asking the 10
10
ml
ml
per
per
hour
hour
is enough to
to
start with.
protect the gut.
Yeah, that's what my talk is only that one, not for feeding,
But
David.
what they are telling, there is no perfusion to the gut because of shock. It won't absorb, but you won't help in maintain the barrier mechanism also. So try to pick up the hemodynamics, then start the feeding. What they said in nutrition topics. Another question, Srikar. Did you read that book called 10% Human? Srikar?
No, sir.
Long back, means 10 years back, Dr. P.V. Satyanarayana, cardiothoracic surgeon, asked me, what is your percentage of human body? I said, I'm human body, my 100%. Then he said, no, you are 10% only. And go read book called 10% Human.
I'll pick up,
What
sir.
he said, your brain, you mentioned all these central microbiota functions related to
Actually,
all the
David,
organs.
I remember only PV Satyanarayana when this talk presentation came by Srikanth.
అవును సార్ అదే నాకు కూడా అదే
I remember him. Actually, I sent him a link. I don't think he has seen it.
Yeah.
Not. He didn't see, I think.
Yeah, we can ask him to take one class on this also by P.V. Satyanarayana sir. So what he said, your appetite, your thirst, your emotional this thing, or your intelligence, and even the human sexual desires also depends on your microbiota, not by you. So everything will be decided by
I just want David.
sir.
Very happy that Ravindra Reddy sir joined the link. Sir, Ravindra Reddy sir, welcome sir. Good morning, sir.
Good morning, sir.
Good morning, sir. I think Dr. Ravindra Reddy sir will give a good explanation on my question.
We have to ask him. It's just fresh, no? Ravindra Reddy sir.
Thank you very much for the invitation.
No, not
Sir,
at all,
good
sir.
morning,
It's a pleasure. It's a pleasure having you with us amongst us, such a senior and expertise and experienced and exposed person. And the surgeon. And the gut surgeon.
I had your classes, a number of classes, even in national conferences. You came to Visakhapatnam also to give a talk on nutrition, sir.
Thank you.
Sir, my question, a book called 10% Humans. Dr. P.V. Satyanarayana sir told your mind, your appetite, your desires, your emotional status, and even your human sexual desires also depends on the bacteria.
Yeah, there is
Microbiota.
growing evidence. Talking about 10%, we are not, in the past, when this book came out, we thought we were only 10% human. But now we know that there are about 37 trillion cells approximately in our own cells. And there are about 38 or 39 trillion microbes in us. And at times, the innate cells, our own cells and the microbes equal, especially after a bout of loose motions or bacterial expulsion in the form of feces, especially because most of the bacteria are within the large intestine. Having said that, there is amazingly increasing research on the role of these microbes, which affect the psyche. In fact, they produce, it's not that the microbes have a direct connection to the brain. It's not that they induce a connection through the vagus nerve, even though vagus nerve forms a very, very important avenue and a pathway for these molecules to act. These are actually called as psychobiotics. There's a new term, psychobiotics. They are nothing but postbiotics. As we all know, it is a topic of prebiotics and probiotics. Somebody would have already defined. And also somebody would have already defined what is a postbiotic. These are the small molecules which the beneficial bacteria and the beneficial organisms in our body actually produce. And the example is short chain fatty acids. It is so small that it will easily percolate and penetrate most of the barriers, including blood-brain barrier, and go onto the brain and affect many other things. Now, talking of the various urges, especially diet, we know very well that the nature of the bacteria in our intestines actually dictate what we eat, or they increase the desire of what we eat. If you put let's say a bowl of salad and a bowl of a nice chocolate in front of a kid, obviously the kid will eat the chocolates, and we think that, oh, the children like chocolates, and we don't give much importance. But the same thing if you keep in front of an adult who's a diabetic, you put a bowl of salad and let's say a big bowl of hot streaming gulab jamun with ice cream. What do you think the diabetic person will have? He will go for the gulab jamun. And that's because even though his mind actually, his prefrontal cortex is telling him, hey, this is not good for me, but still it is overridden by the firmicutes in the bacteria within the large intestine, and they actually generate so much because they want these particular high caloric dense foods, especially simple carbohydrates. Even though the salad also is a carbohydrate, they do not want the complex carbohydrate, but they want the simple carbohydrates. So yes, we are dictated by what we eat. We know there is ample evidence now to show that the depression, the amount of mentation, our moods totally are directly in proportion with the kind of bacteria we have in our intestines. But what is emerging now is actually the kind of sleep. We all know that in addition to the REM and NREM sleep, we also need the deep sleep. At least about 30% to 40% of our sleep hours should be in deep sleep. That is when we drain all the lymphatics from our brain and blah, 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 very many things. And this can happen only if we sleep well. And it is the bacteria that actually evolved us to actually get into this deep sleep. And given the modernity of our diet, when I say modernity of our diet, even though we eat vegetarian diet, which is in Telugu, Annamu, Pappu, and Charu, that is a junk food as far as health is concerned. Most of our diet is based on this. And we say, I'm a pure vegetarian, I eat healthily, but still, they don't sleep very well. And that is the beginning of it's something like the effect where one leads to the other. Coming to the sexual desire, I'm not too sure about that because I have read quite a bit of the role of psychobiotics, but probably it does play a role. But I'm not too sure of any of the recent evidence of that. But having said that, we think we are what we are mainly because of the gut microbiomes. What is important is our moods, what we eat, how we sleep is basically what we are. That is the physiological side of it. The pathological side of it is how we respond to an antibiotic, how we respond to an intervention such as chemotherapy, such as radiotherapy, or even surgery actually depends on the nature of the gut microbiome which we have. So it is very essential to have a good microbes, a set of good microbes in our intestine. Mohan.
Sir, thank you, sir. And just another one or two questions, please. See, normally when in ICU, as you know, you're a good surgeon as well as you take care of a lot of ICU cases. I know very well. So in early nutrition, whenever we want to give early nutrition, as per protocol or our guidelines, they say if the BP is low, below 90, not to feed, and at least wait for 48 hours or till the hemodynamic stability is there. But there is another sentence that maybe 10 ml per hour of just not for feeding because of gut emptiness, translocation theory, and to prevent infection to start with. So I feel personally that the earliest we should start even the patient in the shock in the tropic feed. So what's your take on that, sir?
Yeah, there is very good evidence, especially this evidence actually has come even from this huge amount of COVID cases which we have. If somebody is on vasopressors or inotropes and the mean arterial pressure is 50 and above, we can actually start or commence or continue the trophic feeds or minimal enteral feeds. of 10 ml, 15 ml per hour. The importance of this is not to provide calories to the individual, but to maintain the gut integrity, because as we all know that the largest numbers of gut bacteria, both and their toxins, exotoxins, endotoxins, are within the intestines, and we only have a very single layer of epithelium that actually keeps away, covered by a very important, for example, if I show this is the layer, and this pink one is the mucus layer. This mucus layer is very important to actually repel the bacteria. They also avoid the bacteria to get adherent to the mucosal wall. And by fasting, this mucosa actually fades away, right? And so it is so very important to have this mucosa. And the only way to maintain this mucosa is actually by feeding the patient. And I always use the statement, we don't have to feed the patient chicken biryani or any other huge stuff, but at least minimal enteral feeds of 10 ml, 15 ml. Somebody who is on escalating dose of vasopressors, right? He is not stable, and it's very, very difficult to maintain even 50 millimeters mercury of MAP, and he's on dual dose, double dose, and it's 20, 30 of adrenaline, vasopressin, and we have to add it in addition to the norad and vasopressin, even adrenaline. Then that is a time where we need to think of, hey, we need to stop that and we need to resuscitate the patient. But a patient who's on stable inotropes, MAP is 50 and above, then you can safely start or continue minimal enteral feeds. This has been published even in the US guidelines, the Aspen guidelines, and the European guidelines as well. Mohan.
Sir, thank you, sir. Thank you. And another thing is, normally this healthy fecal, as we said properly, now there's a guideline and proper protocol. How do you really take care of the cleanliness and how much to feed? Again, what is your call on that, sir? Because 30 ml of it.
Did you say healthy pickle?
Sir?
Did you say
fecal now?
Oh, yeah. That you're right. Fermented foods.
Fermented, yeah.
Fermented foods. In fact, there is an
not fermented.
No, sir. Fecal matter transplantation.
FMT, I'll come to that in the second aspect, but let me answer this very important question of fermented foods. There's an amazing prospective study done by Justin Sonnenberg and his wife Erika Sonnenberg from Stanford University in California in US. What they have done is they have taken 36 individuals, healthy individuals. We can actually extrapolate this to our patients, healthy individuals, and they divided them into two. The 18 of them were they were put on high fiber diet, and the other 18 were put on the high fermented diet. In fact, this study is called fiber fermented diet. It's free on the net, or I can share this amazing article with you all because I subscribe to this journal called Science. It was published there about 1.5 years ago. And they took about, in the first 3 weeks, they only collected the blood samples for interleukins and the various other inflammatory molecules and the stool samples for the first 3 weeks. Followed by the next 4 weeks, they gradually increased the fiber in the fiber group and gradually increased the fermented foods in the fermented group. And for the next 6 weeks, they continued to have a very high fiber diet or a high fermented food diet for the next 6 weeks as respectively. And following that, they had a ramp down period where for the next 4 weeks, they had whatever they wanted to have, both fermented group as well as the fiber group. And during the entire session, once in a few days, they collected the stool samples and the blood samples. And guess what they found? They found that those who had a very high fiber diet, they increased the diversity, which is no surprise to anybody. They increased the diversity of their gut microbiome compared to the initial phases. Now, those who had high fermented diet also increased their diversity. In addition, they increased their anti-inflammatory molecules. The IL-6 drastically fell down. The tumor necrosis factor drastically fell down. There are various other molecules, small molecules, which all of them have actually drastically have fallen down. So the message from this particular study, amazing study, is that for our patients who are on antibiotics, because and we know that probiotics have there's a level 1A evidence for probiotics and prebiotics and symbiotics for these patients. Instead of giving artificial ones, we can actually give this patient the high fiber diet and a high fermented diet. Now, what are the high fermented diets? For fermented diets, we eat that regularly. One is yogurt. Even though Greek yogurt is much better, they have more, but then in India, all of us can't afford. Maybe it's not available also. So regular yogurt will do. Cottage cheese, that is the paneer, which we call cottage cheese, that is again fermented. There are many fermented pickles in India, I do not know, but what I know and what I consume personally and what is available in most of the Indian cities, tier 1, tier 2, tier 3 cities, is actually the kimchi and the sauerkraut and the kombucha drinks. Kimchi is available as a fermented cabbage. For those of you all who want to increase your fermented diet, you can actually go to the YouTube and you can use cabbage and other things and buy an airtight jar, and actually it's very easy how to make this fermented diet. So it actually helps a lot, as, not only to us personally, but also to our patients. This is about the diet. Now coming to the fecal FMT. Now, this was found out after the Hadza community from the Tanzanian. In Tanzania, there's a big community called Hadza. They still are the hunter-gatherers. They do not work. They only hunt. They still live in the prehistoric way. And many of these researchers, including Justin Sonnenberg and many others, have went and lived with them and ate what they ate, slept the way they sleep. You know, they live their lifestyle and whilst checking their fecal microbiome. And they found that they had the same amount of microbiota. Now, what had happened was one of these individuals, one of these researchers, developed a severe acute diarrhea. And he collected the the feces of this Hadza and through a rectal tube inserted to himself. And he found that immediately, he actually improved. And then when he came and published this particular thing, this study was actually done in quite a few centers rapidly. And right now, at least in diarrhea due to Clostridium difficile and those pediatric babies with necrotizing and NEC and enterocolitis, they found that if you take a healthy microbiome from an individual and give it in the form of a rectal tube inserted, or you can put a nasoenteral tube, or in the form of capsules, delayed capsules, freeze-dried capsules, which are released only in the small bowel, then there is adequate evidence that it actually helps in these individuals. Right now, we don't have much evidence for FMT, the fecal microbial transplant, except for Clostridium difficile. But then research as we speak is going on for the other things. And the downside of this is, remember, we have the largest amount of microbes in our intestine are not the bacteria or not the fungi, but they are the viruses. They are the bacteriophages. A huge amount. They actually are at 1:10 ratio to the bacteria. They are about 1:100 ratio to the human cells. And quite a few of them, we do not know whether they are helpful or not. At the same time, hepatitis A, B, C, RVD, retroviral disease, all of them are very rich in the fecal matter of these. So it's very, very, ethically, we have to be very, very mindful of the fact that instead of blindly transferring the feces of a healthy in quotes to somebody, we may be transmitting it to. So presently it is being done only in research centers or in those centers that have the wherewithal and the capacity to actually test the fecal matter for if the donor is carrying any of the harmful viruses or other harmful bacteria. But FMT does have a role in a limited number of cases and situations. Dr.
Thank you, sir. Thank you. Sir, another thing you told that the dal, rice, and this is rasam is not really a healthy diet and it's not actually this one. But as I was reading before long back, I'm not sure about it. What I was thinking about all essential amino acids are present with Dal and rice.
I will take back that word. I didn't say, I shouldn't have used the word. I said it's.
No. Please. Not like that, sir. I understand.
No,
I understand
it's
your
like
mind.
this.
I understand. Just
Dal
wanted to
and
reassure.
rice is a very good source of protein. If you're eating rice, it's better to add the original fiber, not remove the fiber. So it's better to have the black rice, it's in black in color, or even the brown rice, or wild rice, or red rice, all of them where the husk is intact. Then dal, which is pulses, they are very good because if we combine various pulses, legumes, and the seeds and the nuts, you get all the essential amino acids, and that's where I get from. My diet, I'm actually a vegetarian. So I get all my essential amino acids, including my vitamin B12, from various plant-based sources. So what I meant was, instead of just having rice and dal in the form of rasamu or pucharu or whatever you call it,
Yes, sir.
you should also have vegetables. That's what I meant.
I understood.
The thing is, right, 50% of our meals plate should be vegetables. The way I tell my patients is actually 1:3. For every cup of brown rice, have 3 cups of vegetables. Or for every 1 chapati made up of whole wheat, have 3 cups of vegetables. In case they would like to have a second chapati or a second cup of rice, have 3 more cups of vegetables with them, right? So in that way, we are maintaining, we are having the cake and eating it too, if I have to use this terminology. Mohan.
Yeah. Thank you very much, sir. And as you said rightly, the fermented food is one of the important point you made us to learn. And the new one where I don't know because how important it is, because I just got a few sentences missed, but still it was really nice. Do you have any class, sir? Because a lot of classes are there. Can you just send us one link of your class which is important about fermented food and other things?
There's a class which I talked about this at the recent Pensa, but that was purely related to the surgical side. But it's at the back of my mind to actually have one under the aegis of our society to have fermented foods, because it's an amazing one. For those of you all who are curiously minded, please get a book called Psychobiotics, The Psychobiotic Revolution. It is published by the National Geographic Society. And even though it is written by a non-scientist, there are 2 scientists who actually are involved in the real clinical work. Both of them are from from Ireland. The Psychobiotic Revolution. It's an amazing book.
So nice, sir. So nice. I think we have a Srikanth Bachu who is actually good in reading because he's a member of Pick a Book, and he is a BNA member who actually makes the presentations after going through the book. Am I right, Srikanth? So, Srikanth, you take this book.
Already searching the book.
Yeah, I know. So you please go through this book and
send a screenshot of that to Mohan, and you can pass it on to Srikanth.
Yeah. He will read it and present to us in the next, maybe by next year, first class or something like that. He will do, sir. Really nice. And I think so many people are there. I don't know why people are not talking. Jekina, Dr. Rani, and other people are there.
Any questions from others? Hello?
Yes.
Please ask. Sir, my question, practical question in critical care. Majority of the patients in admitted in critical care, they are getting antibiotics, higher antibiotics that will kill the the bacteria. Is it necessary to give a probiotic or prebiotics to all the patients admitted in ICU who are on antibiotics?
We are not sure at this point of time, because they are very good, even though there is a level 1A evidence to say that those who are on antibiotics in at least non-critical areas, if it's combined with with a probiotic or a prebiotic, it actually helps. A word about that, I actually tell my patients to have an interval of 1 hour between the antibiotic oral dosage and the prebiotic, because otherwise, at the same time, most of us give this Econome sachets, anything that is sachet, because the gastric acid actually destroys them. Give it in the form of capsule form, which is then released only in the small intestine, or they have to be released only in the small intestine. Now, having said that, There have been quite a few studies to show that those who are very severely ill with an Apache of more than 12, and in them, or those who have very high leaky gut syndrome, they go into a system, something called as immunoparesis. At the same time, those who are on constant steroid usage and immunosuppression due to post-transplant. It is these, even though these bacteria are beneficial, remember, these can become pathogenic given the right circumstances. It's not that they are best friends forever. Especially this study has come from severe acute pancreatitis, where they found that those who were on pre and probiotics, their mortality had increased drastically, especially in ASAP, severe acute pancreatitis. Dr. Paul Wishmeyer, all of you all know him. He's got amazing results, especially if he uses the lactobacillus. This particular species is called the Lactobacillus plantarum. Most of these are available. If I have to use a trade name VSL3, it's very rich in that, or even our simple yogurt is very rich in that. If your patient is quite stable, you can actually give these to your patient. But if your patient is deteriorating and depending on if it is less than, let's say, Apache 2 is less than 12, then yeah, definitely there may be a case to actually give pre and probiotics to these patients. But a very acutely ill patient, with severe intensity and worsening Apache 2 scores, worsening SOFA scores, it's better not to use them. The third thing is, there are some fibers, both soluble and insoluble fibers, available in the oral nutrition supplement formulations. We can use them, but once again, there have been reports saying that if we use these in patients who are on high doses of inotropes and vasopressors, it can lead to the translocation of these into the systemic circulation, in addition to causing mucosal ischemia of these patients. So we have to be very mindful of that. So we have to individualize, is what I'm trying to say. I'm not saying that you should not, you can, but you have to individualize. See how sick your patient is, how stable your patient is, and then perhaps you can use any of these. Because it takes about, on an average, it takes anywhere between 6 months and above to actually replace all the healthy gut microbiome once we give a broad spectrum antibiotic of more than 5 days duration. And we all know that our trigger to start a high-end antibiotic, especially in ICUs, is very, very low. The moment they come, we actually start with the 3rd generation or 4th generation cephalosporin, or even a beta-lactam or piperacillin tazobactam, right? And that's why no wonder all of us who work in big centers, we have MDRs, we have multi-drug resistant bacteria, and we have to fight with them. The only answer to them appear to be bacteriophages, but we have to wait for that to be used in clinical practice. But we have to be very careful in ICU patients to use. We have one option to use fiber. It's better to use them because it also helps in diarrhea and other issues, bowel issues. But you can, but you have to individualize the usage in your respective patients or particular patients. Sir.
Thank you.
Yeah, thank you.
Hello.
Sir. Thank you.
Madam.
Good morning, sir.
Good morning. Dr. Lakshmi, good morning.
Oh, hi. Good morning, sir.
Morning.
Thank you for very good advice and information about this. Sir, we have seen so many patients who are discharged from ICU and going to rehab centers, who constantly have gut dysfunction and diarrhea problems for days together. So as you said, like it can last for months together. So how long should we really give probiotics or any supplements to avoid this or prevent this continuous ongoing dysfunction?
It's a very good question, Dr. Lakshmi. Very practical question as well. Because the synthetic symbiotics or pre and probiotics, they are the artificial way of giving these beneficial bacteria. But then no other go. Our patients are not in position to have a high fiber diet or a high fermented diet. So we have to give these. Ideally, I give it for at least about 2 weeks following, because there have been studies to show that.
But we can give fermented food, no, sir? We can give fermented food to these people?
Yeah, I'm talking about the synthetic capsules. We can give about 2 to 4 weeks. Whilst at the same time, I was coming to that, Mohan, whilst at the same time encouraging and educating the patient or his or her minder or carer to actually inculcate the high fiber and high fermented foods. And you can tell everybody, most 9 out of 10 of our individuals would like to have yogurt. Only thing is you have to tell them that to keep away from sugar. The moment we say yogurt, they think of adding sugar. Remember, sugar is an inflammatory molecule in any form, simple form, in any form. That we know from 2002 onwards, sugar is inflammatory. So already our patients are gradually convalescing from having seen a huge bout of a systemic inflammatory response syndrome. We should not be increasing the inflammatory response. So we should be telling them to actually reduce. When I say sugar, it means honey, it means fruit juices. All of these simple carbohydrates, including white rice for that matter. But then many of us have white rice on its own. We can actually combine white rice with yogurt or the white rice with dal and other things, and white rice with vegetables, so that the glycemic index is gradually lowered, or not gradually, but significantly lowered. So encourage all our patients, those who can chew, to have the high fiber diet and high fermented diet. Those who cannot chew, tell the minders to actually take the vegetables and overcook them and see that they have. Those who cannot chew, we can actually get over there. A significant number of our patients are post-extubation patients, and they have some sort of an odonophagia. They can't swallow properly, and some of them even may be aspirating. So we need to again educate the relatives to give them semi-solid and solid diets, because the incidence of aspiration is quite less compared to a pure liquid one. And at the same time, not very hard diet to swallow, but semi-solid diet to actually, so that, and the moment they have a significant cough or unexplained fever, immediately to come back to us so that we actually rule out whether the patient is aspirated or not. Yes, the other big challenge we face after their discharge is, apart from the gut microbiome and the weakness and the drastic anorexia persisting for weeks together, is actually the sarcopenia. And we know that the amount of muscle mass at the time of admission equals to his or her survival rate. And so and everybody loses everybody loses muscle mass when they are admitted to the hospital, especially so in the ICU. So we need to actually encourage them to have a high fiber diet. If they are vegetarian, to have mixture of. We need to be aware of how to provide all the essential amino acids, and a high protein diet of at least 1.2, 1.4, or at times even 1.5 to 2 grams per kilogram per day, along with adequate amounts of carbohydrates and good fats and micronutrients in the form of trace elements, minerals, and vitamins. At the same time, inculcating in some form of an exercise, either doing a hand dynamometry or, doing a simple exercise, taking a 1 liter of bottle of water and doing a simple resistance exercise, in addition to the passive exercises, even the active exercises, because just by giving proteins will not increase the muscle mass. The person needs an anabolic stimulus. So it's a challenge. Actually, the challenge starts for the healthcare professional, not from when the patient is sent from the ICU, but the challenge starts once the patient leaves the hospital premises. And that's the biggest challenge. And that is a transition in which most of our gaps need to be filled very drastically. And that is our need to be filled gap, which we need to address very, very mindfully. Dr. Lakshmi.
Thank you, sir. Thank you so much.
Thank you very much, sir. That's the reason that in particularly in ICU, we make sure that 8 hours of morning, 8 hours of evening, physiotherapist is must in ICU to stay all the time. And that was a very nice. And Dr. Srikanth, I want to give you responsibility of Dr. Ravindra Reddy and Dr. Sriram to bring on March 4th or 5th to conduct a reflect. So both of them are going to be excellent. And actually, I took the word from him in last month itself in Spain. I think, hope you remember Ravindra Reddy, sir.
March.
March 4th or 5th.
Okay.
Hope you are in India.
Yeah. I'm going May. Sorry, I heard it as May. May, I'm going to Japan.
No, March.
March. Yeah, March, I'm there.
Sure. Thank you. Srikanth, you take this responsibility and we'll do that.
Thank you again for the invitation.
Thank you, sir. And really, thank you for last minute suddenly accepting our invitation.
Not at all. My pleasure.
Yeah.
My pleasure.
Thank you, sir. Thank you very much for
Srikanth, thank you,
your
Srikanth.
nice explanation. Thank you, Srikanth, for your nice presentation.
Thank you.
Thank you all.
Thank you, Srikanth.
Thank you, madam. Thank you, sir.
అంటే నేను
Thank you,
మాకు మాత్రం
Srikanth.
థ్యాంక్స్ చెప్పారు ఓన్లీ మేడం ఒకరికి థ్యాంక్స్ చెప్పేసారు శ్రీకాంత్ అన్యాయం
Sir,
మాకు ఎవరికి ఎన్నిసార్లు చెప్పినా సరే మాకు చెప్పలేదు థ్యాంక్స్ అని కూడా
sir, basically గుర్తుపోలేదు.
నేను స్టార్టింగ్ నుంచి అంటున్నాను థ్యాంక్ యూ శ్రీకాంత్, థ్యాంక్ యూ శ్రీకాంత్.
అయినా నీకు చెప్పలేదు చూసావా
థ్యాంక్ యూ మేడం అన్నాడు
చెప్పలేదు,
అంతే.
నాకు చెప్పలేదు
Thank you, sir. Thank you. Thank you, sir. Thank you.
Okay, Srikanth, as you said, you get that book. What is psychopath?
Yeah.
Actually, psychobiotic.
Psychobiotics, sir.
Psycho
కొంచెం
something.
psycho
You
something.
catch that psycho and
పండగ టైంకి డెలివరీ ఉంది సార్, చదివేసి. Sure.
thank you very much. Bye.
Okay, thank you.